Oops. No. Got it. Okay. Welcome, everyone. Really appreciate everyone joining us. And we have today Amanda Goodenow and hopefully Julie Walker to present to us. And this is the task force meeting for the fall prevention in the Methow Valley. And we've been looking at programs in the last couple of months. And we've looked at so far Matter of Balance, the SAIL, Otago, Stepping On, and Tai Chi Quan that information has been provided to us so we can have a discussion about implementing one or many of these in the Valley. And I think Tracy said we'll be starting SAIL next month. And Capable is the program that is going to be presenting today. And this is the one that's from Johns Hopkins University School of Nursing, and they've been very successful utilizing OT nursing as well as handyman. And Amanda's here from Colorado. She's had 17 years of experience as an OT, and she's on the Johns Hopkins Capable team, and her role is to implement and provide clinical support. So Amanda, thank you. Really appreciate it.
Absolutely. All right, so I'm going to, where did my screen share go? Oh, right there. Can someone give me rights to screen share?
Deirdre? Uh-oh.
Yes.
Okay.
Sorry. Okay. Okay, you should be able to do it now.
Okay, can you see it now?
Yep.
Perfect. Okay, let me just move my videos. Okay, so yes, I'm Amanda. I am an occupational therapist. I'm here in Denver, Colorado. So I've had 12 years of experience in the home health setting, but I've been implementing Capable also here in Denver for 5 years. So we started the program in 2017 and have seen really fabulous results. I then joined the JHU team approximately 2 years ago to assist with strategic partnership along with implementation and clinician support. I also continue to see Capable clients myself because I love the outcomes that I'm seeing with the clients. Capable, it stands for Community Aging in Place, Advancing Better Living for Elders. We see a lot of these key issues with older adults in our communities, but they aren't always addressed in the traditional services. Losing our independence in our current environment that we know and love is really, really tough. Many of us here today may share same concerns for not only ourselves, but also maybe for a parent, an in-law, or a client, or another person that you may know, a friend. Most don't want to go to an assisted living or a nursing home, or they can't afford a decent one. However, ending up in long-term care is often what happens. The things I've listed here, we see often: weaknesses, multiple comorbidities, difficulty with ADLs, can't maintain the home, caregiver health decline or emotional strain and stress, dementia-related behaviors, and money issues all relate to these issues that we're seeing in our communities. Often these changes are gradual. People shrink and they can't reach their microwave anymore or the top shelf or their closets very well. Their legs are getting weaker, so they can't go to the basement to put their laundry by themselves. Or they can't afford to repair the carpet that has completely worn a hole in it and is now a huge trip hazard. Capable is a tri-discipline approach that includes 6 OT visits, 4 nursing visits, and home modifications from a handed person. The program is approximately 4 months long with a limited budget for simple modifications and adaptive equipment or durable medical equipment. The client formulates 3 goals of their choice, and I emphasize their choice. with the OT and 3 goals of their choice with the RN. 1 goal is addressed at each visit. The program is client directed, not centered. Through the program, we are promoting self-efficacy, we are connecting cultures, and we are solving problems and customizing as needed with each client and their goals. We are addressing the environment not only for their current needs, but also for future needs in order to provide some prevention. Here's a timeline of what the program looks like within the 4-month period. The OT makes their first visit and completes a capable assessment. On the second visit by the OT, goals are formulated and a home assessment is completed. Here is where we put together the work order. The first items on the work order includes the client's goals and the items that need to address the goals. After the items needed to address the goals, then we put on the work order the items that are needed for home safety and independence. This work order is then sent to the home modification specialist. From there, the home modification specialist calls the client to set up an assessment day and to set up an install day. This all occurs between the OT's 2nd visit and 5th visit, preferably sooner in the program versus later. After the OT's 2nd visit, the RN makes their first visit and completes the capable assessment. Here, the RN also formulates the goals with the client. From here, the visits from the OT and the RN are approximately 3 weeks apart and staggered out in space. Having the visits spaced out provides the opportunity for the client to practice the strategies between visits in order to, 1, see if the strategies that we came up with are successful or not, and also provide that opportunity of habituation. What has the research found so far? This study here compared 5 home-based care models. What it found was that Capable had cost savings of almost $2,800 yearly per quarter or per yearly quarter per client over a 2-year period, which is more than a $22,000 savings over that 2 years by decreasing hospitalizations and emergency room visits. This here was a CMS trial of approximately 280 clients, and it showed significant improvements in ADLs, IADLs, depressive symptoms, and home hazards. The evidence is out there. The program cost approximately $3,000 per client to implement. Through the program, we are able to drive down medical expenses by reducing inpatient and outpatient expenditures. Along with decreasing health costs, we have found that those participants have had on an average of a 50% decrease in their difficulties with ADLs, along with overall improved motivation and reducing the symptoms of depression. By simply changing the physical environment that the client lives in, we are truly assisting them with being able to thrive at home. There are 5 features that assist people to age in place that are found in homes, I guess I should say. A no-step entry, to live on 1 level, wide hallways and doorways, accessible outlets and switches, and lever handles and faucets. Approximately how many homes, or a percentage of how many homes in the US do you believe have all 5 features? Any guesses?
10%.
10%? Anybody else?
5.
1.
I mean, it's just really unheard of.
Wow.
So through this program, we're able to go in, and we're not able to obviously eliminate these and provide these options, but we're able to provide modifications that are adaptable and to help with aging in place. So now I'm going to provide 2 case studies. This is Mrs. D. She's an 87-year-old female who lives in Baltimore. Past medical history includes diabetes, hyperlipidemia, peripheral neuropathy, and obesity. She lives with her husband, daughter, and granddaughter in a 2-level row house in Baltimore. Her bedroom and bathroom are on the 2nd floor, and then she has 6 steps to enter her home. So the goals that this client came up with the OT, one was to be able to get in and out of bed easier, to be able to get on and off of her bedside commode easier, and to be able to wash her hair in the kitchen sink. So when the OT addressed these goals, first on the work order were the items that were needed to address the goals. So the first item on the work order are going to be the items related to getting in and out of the bed easier, which the OT came up with bed risers and a bed rail. Then the second items on the work order address the bedside commode. So the OT found and purchased her a wider bedside commode. And then when it came to washing her hair, she purchased a chair cushion to elevate the height of the chair in the kitchen, and then purchased her a long-handled comb and brush. And then the next items on the work order were going to be related to falls and independence and safety in general. So she purchased a chair to go at the top of her stairs to sit on for her to rest after ambulating the stairs before continuing mobilizing to her bedroom and bathroom. And she also put on the work order for the handy person to implement railings, both inside the house, an additional railing for the stairs, and outside of the house. The RN goals. Her goals with the RN were to understand how to take her medications and to move more. So the RN was able to purchase a pill box and then provided her with a medication calendar. The medication calendar is some of the materials that we provide in the Capable program. This provides a way of the nurse organizing the medications on paper, describing what they're taken for and when and why to take them. And then the pill box was just to help her keep organized with her medications. And then to move more, the nurse came up with goals of 1, how often do you want to move? What's a reasonable expectation for how long and things like that. And then there's also some exercises that are provided during the program that the nurse provided and set up that movement goal with her. Her results. She had a decrease in difficulty with her ADLs by 50%. She felt like she fully met her goals by 75%, and her depression score reduced without medication. And her cost of the program was approximately $2,800, almost $2,900. When I say the cost of the program, that includes the OT visits, along with the modifications, the supplies, and labor costs, along with the nursing visits. This is Mrs. O. She's a 66-year-old female who lives in Denver. She has multiple sclerosis, and about 3 months prior to her implementation, her entering the program, she had COVID. She moved to Colorado in order to live with her sister who could provide her more support. She does have children back in Missouri where she lived. However, they were unable to provide her the support that she was going to need. Her goals. 1 was to be able to get in and out of her garage by herself. So the items on the work order included platform steps to decrease the height of the steps and also to add grab bars and railings. We did add some strips on the steps in order to provide some friction, just to add a little bit more safety. Her strategies that we came up with, 1 was to hold on to the grab bars with both hands. She had really strong upper body strength, pretty impressive. So to hold on and go down forwards versus sideways. Before she was going down sideways, but we found when we added the grab bars and the railings, going down forwards was a lot safer for her. And then also making sure she was resting before she was going down. So sitting down at the door before managing those stairs, along with before coming up the stairs, making sure she was resting. She also wanted to manage the stairs inside of her home by herself. So with this, we've added additional railings as well. So she had a railing on both sides. Another option would be a stair glide chair. So some programs throughout the US have what we call critical home repair funding. They either have it through the grant that they received or through maybe other organizations that they use outside of Capable. So we try to look into situations like that where if there is additional funding that we can use for larger repairs in order to promote safety and independence, we do. So the strategies we went up with for her were, one, she started talking about, when we were discussing stairs inside, she started talking about even stairs outside of the home in the community. We talked about avoiding those and trying to find curb cutouts. She had the ability to sit down on a step and pull herself back up with the railings. So we talked about if she becomes fatigued, to go ahead and just sit on that step and rest so she doesn't take the chance of falling. We also placed a chair on the landing. So she completed half the stairs, would sit on the landing, and then complete the other half. Her third goal was to be able to get in and out of her tub shower with more security. We didn't need to provide modifications here because she already had grab bars in place. So the strategies we talked about were a lot of energy conservation. Sit and rest. Use a fan to keep the room cool. Sit before you get in the tub. Before you get out of the tub, rest. We added a tub mounted grab bar for her to hold on to for support. We put in a anti-slip mat in the bottom of the bath, and also to keep the door cracked to let heat out. And then have her sister upstairs just for the added security, so she felt more comfortable. Her sister wasn't present when she was bathing, but just to have her in the room or on the second level with her when she was trying to do that. Her nursing goals. One, she wanted to prevent falls. She was so worried about falling all the time. So the nurse talked to her about hydration, making sure she was staying hydrated and that she wasn't having issues with low blood pressures because of hydration. Also discussed time management opportunities. So again, it came back to the stairs. So there is some overlap between the OTs and the nurses sometimes, and that's fine. But she was really worried about falling down the stairs. So she talked about managing her time. So prior to doing stairs, making sure she's not overdoing other activities before managing the stairs. She also wanted better sleep and a better routine. So the nurse ordered her a sleep spray that had like chamomile and lavender in it, and then talked about reaching out to her physician about the cramping that she's having at night, and then provided her a health passport, which is also materials that are provided in the Capable program for the license and things. Her third goal, as you can see, is not a traditional goal for a nurse. However, we work on the goals that the client comes up with us. So she wanted to organize and declutter her closet. Again, here come those energy conservation techniques. So as you can see, we're trying to provide an opportunity for them to generalize these strategies across the board. So they don't think they're just for one thing, they can be used across the board. Taking frequent breaks, making sure she's trying to do these activities on cooler days or maybe earlier in the morning, and then again, sit to complete the tasks. Mrs. O's results. Her ADLs remained the same. She still had difficulty in 3 ADLs, but she does have the diagnosis of MS, so that really wasn't surprising for us. However, her instrumental ADLs improved. She was no longer calling her sister to come up and help her with getting a drink or a snack. She was doing those tasks on her own now. She was also able to get out in the community more often. So prior to our implementing Capable, she was getting out in the community about once a week to go have coffee with her brother-in-law. And after the implementation was completed, she was now getting out in the community once a day, maybe sometimes even twice a day. She loved going to Walmart and just riding around in the scooter at Walmart just to get out to see people. So this was huge. Getting out in the community and that re-entry was really big for her. Her depression score improved as well, and her overall perception of her health. So we asked people, how do you feel? What do you feel like is your overall health right now from 0 to 100? And when we started, she was at a 60. And when we were done, she felt like her health overall was at a 100. That's huge. When people feel better about themselves, it makes a huge difference. And then her confidence in not falling. Again, we provide 10 tasks. How confident are you in not falling with these tasks on a scale of 1 to 10? When we started, she was at a 67. And when we ended, she was at a 99. Her falling concerns and thoughts no longer consumed her every move. Her total cost for the program here in Denver was just shy of $4,000. If we had added the stair glide chair, her cost would have been about $8,200. You know, and when you think about the grand scheme of things, with her having MS and the progressive diagnosis, an assisted living starts at $5,000. So in 2 months, you've saved money in this case. Through the program, we are really trying to improve and increase communication with primary care physicians. When older adults have good communication with their primary care physicians, there's a smaller percentage of hospitalizations and emergency room visits. Often these issues can be resolved by reaching out to the PCP when concerns first arise versus waiting until things become more serious. This again comes to the point of teaching the older adult to problem solve as the difficulties arise. So far, there's a variety of organizations that have started Capable in their community. The Capable team at the National Lead assists these startups. There are several ways of starting the program by looking into funding options through grants, partnerships, or self-funded. As part of the lead team, we want to help these organizations become successful with their initial experience and have the ability to scale as they are able. As far as state Medicaid, there are 5 states that have funding so far. One has begun implementing, and the other 4 are in the process of formulating their rollout plan. We are in 46 communities currently in 20 different states. And Alaska is one of them. I couldn't find a map that had them up there, but they're part of it.
It's okay. I'm on the call, Amanda.
Oh, yay!
Hi, Julie.
I'm so excited. Yeah, I was like, we can't leave them out, but I couldn't copy and paste. I was trying to copy and paste the map from the website. It won't let me. So here are the key steps towards implementation. First, contact the Capable National Center to begin the exploratory process. Get commitment from the key leaders. This is huge. I mean, that was the biggest thing for us here in Denver. Being able to start it was that our president and CEO was on board and wanted it. Identify who will be your champion, help lead the effort in the program development phase. Secure funding, make sure your funding matches your capacity, put together your work plan, hire, contract the clinicians that are needed along with home modification specialists, and do a dry run. I do want to emphasize, we use home modification specialists and handy person interchangeably. And we do that because with our clients, if we say a construction specialist or a home modification specialist is going to come in and do work, their expectations are for a home remodel. And that's not what we're providing here. We're providing low cost resolutions in order to increase independence and safety. We're not looking at cosmetics here. So by no means are we devaluing their skill set because we couldn't have the program without them, but we're setting expectations for our clients in this situation. This here is just a short list of the key steps. If you're interested, you can reach out to our team for more details. We will spend a lot less money on institutions if people are able to safely function at home. The overall goal of this program is to empower the client to adapt and compensate as difficulties arise. The program provides them the thought process to age in place. Each visit addresses a goal that the client set. The clinicians help them with breaking down the task, which is difficult, and then come up with strategies for those difficulties. Each visit, we are embedding in the client the skill set to complete this process as other challenges arise. We are overall changing people's lives here. We're also allowing them to stay where they prefer. We're allowing them to stay in their home where they're most comfortable. We're allowing them to remain in those roles of being a husband, a wife, a caregiver if they want to, a mother, a sister, a friend in their current environment. as well. So here are some quotes from clients that we have seen in the past. And one of my favorite quotes is, "It's been a ride, but a good ride. I had given up, but now I can believe in myself." A common theme we have found is the clients state that the clinicians believed in them. That is huge. I've also heard, "You have given me the space to share. You didn't talk to me, but with me." There's a lot of talking that occurs in Capable. So if you have any questions or would like more information, please feel free to reach out to us at capableinfo@jhu.edu. We are here to answer those questions and to help you navigate this program. And then some references. All right.
Well, Amanda, that was a wonderful presentation. Should we go into questions now, or should we have Julie?
I have a question.
Oh, let's have some questions. Okay, go ahead.
It's just a brief question. Thank you for that presentation. I really appreciate it. I was wondering what kind of follow-up happens once the program is sort of technically over. I just wonder, what the strategy is for following up to make sure that people don't backslide or, yeah.
So as of right now, the licensed Capable program doesn't necessarily have a follow-up afterwards. Some programs, depending on funding, some programs do allow clients to re-enter the program at a later date, maybe a year later, if they've had a change in status. Maybe they've had a stroke or something has occurred that has caused them to have more weakness and they would have different goals. But there's no actual set in stone follow-up. But that's not to say that your program couldn't do that. So long as you set that up in your budget and you determine how you're going to do that, I think that's an okay thing to do. But as of right now, the program doesn't have any set in stone follow-ups. One of the big things that we also address is just community resources. Making sure that when we're done, they have those resources readily available to them to follow up with other things if needed. And that's usually provided just during the sessions as we're brainstorming and problem solving issues.
Great, thank you.
Heidi, did you have a question? Oh,
Yeah, I was typing it up.
Okay.
Just wondering where the referrals come from, and then if you had any kind of longitudinal measures of how they're doing a year later or 2 years later. So just
So the case study that I provided that showed the savings of $22,000, that was a longitudinal study over a 2-year period. So the decrease in hospitalizations, and that was a 3-to-1 comparison. So one Capable client to 3 people in the community with same demographics that did not receive Capable in the Baltimore area. And then the referrals, they come from anywhere and everywhere. So this does not require a physician's referral. It's considered non-skilled services. So we're more consultants going in and talking to the clients. We're not providing hands-on sessions. And so the referrals can be self-referrals, social workers. Some doctors' offices do send us referrals. But really wherever the need is where they can come from. So we really reached out to a lot of social workers, some of those community resources, the area agency on agings, and things like that. And each site, the referral base is different depending on who's funding it. But some sites like the Johns Hopkins Home Care Group, they're implementing right now. So it has to be a person that comes from the Johns Hopkins hospital setting, like their physicians and things like that. So each site kind of sets those boundaries.
thank you.
I have a couple of questions. I'm curious how many people your program employs and how many it serves at any given time.
So we serve about 100 clients in a year, and we have So I still see clients, but I'm not in the field 100%. We have 3 OTs that see clients, but they're not 100% capable. So they're not fully dedicated to the capable system right now. Some of them see home health clients as well. And then we have 3 nurses. A caseload is considered a full-time caseload would be about 100 clients in a year is what's considered about full-time. So we have 3 OTs and 3 nurses that are implementing, but none of them are doing it 100% of their time.
And how many handy people?
We have partnered with Habitat for Humanity of Metro Denver for our Denver metro area. And then we have partnered with another company called Brothers Redevelopment for our population in the mountains. And they have one person who manages the program and one that kind of is the supervisor and does all the assessments. And then they have a couple of people that help with the implementation of the actual modifications. So again, they're not all 100% just capable.
You may have answered this question already, and it sounds like there is an umbrella organization that decided to take this project on. Who is that?
So for us here in Denver, it was the Colorado Visiting Nurse Association. So it was a home health agency that decided to implement capable. And then our partner was Habitat for Humanity at that time here in Denver. And so there's usually one company that decides to be the lead organization, and then they find a partnership. And Julie can probably help with that, answer that question too, for what hers looks like there in Alaska. Because so there are lead organizations that are home health agencies, that are nutritional systems. We have some Meals on Wheels that are the lead organizations. We have Habitats that are the lead organizations. We have some ACOs that are the lead organizations. So it just depends.
And one last question. Do you bill for your services to insurance, or do you or how, what is your client's role in paying for this service?
So currently we're 100% grant funded. There are mostly the places throughout the US are grant funded. There are a couple of Medicare Advantage plans in local areas that are implementing it. And then there's one state that has a Medicaid plan going right now for clients in that state, that's Massachusetts. And then there's 4 other states that are going to be beginning a pilot for it. They receive funding through ARPA, but most places are grant funded. Julie, how are you guys? And so that means our clients don't pay for it. It's 100% free for them.
Yeah, we are 100% grant funded. And so we advertise the program as a completely free program. We don't bill anything to the client or insurance.
And Amanda, can you talk briefly, maybe Julie as well? I'll let you present here in a little bit, Julie, but the funding, I think, is significant for us trying to figure that one out if we're going to try to do this. What are some of the sources, the grants that you have received to fund this? I do know that I did talk to there in Renton, there's a capable program being implemented in Renton, and the way the therapist is being paid for is out of pocket. So part of the grant funding. So anyway, can you address that? What are some of your major funding sources as far as grants?
So there's a lot of places have area agency on aging. Organizations are helping with funding. I'm looking at what kind of foundations are locally that are looking at helping people with aging in place is really important. Are there any federal, like sometimes there have been HUD grants out there available for people to apply for to help with people aging in place. It's a matter of just trying to figure out and doing the research because it changes so often. Locally, we have funding through our local area agency on aging. We also just received the funding for Medicaid. We haven't started implementing yet. We're one of the states that is in the process of figuring out the rollout plan. And then there's a couple of small little bitty community grants that we have applied for. Julie, how about you?
Sorry, I had to find the mute. So we're a startup still. We're still kind of this is our third year, but we're still considering ourselves kind of a pilot program. And I'll share a little bit about our program with you in a minute. We have a grant from the State Department of Health and Social Services. And it was this grant was a little bit outside of the scope, or Capable was a little outside the scope of this grant, but we were able to kind of finagle it into like convince our grant funder like why this fits. But it has been a challenge for us to kind of try to fit the Capable program into this grant because it wasn't really designed for aging or fall prevention or home modifications or anything like that. But it's worked for us so far. We also have funding from a foundation. So I think anywhere that you can look for, I mean, we're located within a hospital setting, in a primary care clinic. And so our grant writer has always historically been looking for things in the healthcare field. But we've asked her to kind of expand and start looking things on like those Commission on Aging and also fall prevention. When she's typing in for grant search, there's lots of different keywords that she could be looking for that I don't think she has in the past. So we're trying to kind of broaden that approach, and also housing grants related to housing
Housing
would be
is big.
another. Yeah, that's somewhere we haven't really looked for grants yet, because as a healthcare organization, we've kind of been narrowly focused. Like this is a healthcare, like this is health promotion, but it's also housing. So there could be some grants out there related to housing.
And that's
Julie,
where
I'm curious-
also when some of the housing organizations have taken the lead, they're looking at it from a different perspective when they're looking for funding. So that's always helpful to have just both the health organization and the housing organization working together to find funding. Because you're right, Julie, there are things out there for housing organizations as well.
Betsy?
Julie, I'm curious if you think grant funding is if you guys are seeing grant funding as a sustainable strategy for supporting the program?
That's
Well,
interesting you ask that, because we got a grant that is a 3-year renewable grant. So each year we reapply for the grant, and we're in our 3rd year, just started the 3rd year of the grant, and it ends June 30th, and we're already starting to kind of go, oh, what are we going to do now? So yeah, grant funding is a little challenging when you're looking at sustainability of a program. I think that's why it's great to hear that at the national level, they're expanding and looking at it as a potential cost savings for Medicaid and Medicare. I think that's going to be our most sustainable nationwide and, statewide, the most sustainable way to pay for this program, instead of all these sites having to find grants each year or each 5 years or each 3 years. But I do think it's a highly fundable program because it's evidence-based, because it's across the nation. I think it's a very fundable thing for a grant if you find the right grant.
And there's a lot of work at the national level of trying to get this covered by insurers. Like I said, there are some Medicare Advantage plans that are implementing it in small areas as pilots. And so, Dean Santon and Alice Bonner, they're in DC often trying to promote this and get this further along. It's just, our insurers aren't willing to take the risk of it at this point. But there is a lot of work at that national level so it's not only grant funded, because it's not the most sustainable thing to implement just based off of grants, because you're constantly searching for money to fund it.
Betsy?
I don't know if it's appropriate to be asking Julie questions about her program.
Oh yeah, go ahead. Go ahead.
But I'm curious. So we heard a little bit about how Denver is staffed, but I'm curious how you're staffed and what kind of population you're serving, and how challenging it's been to staff your program.
Yeah, that's exactly what I was going to talk about in my presentation.
Julie, do
So,
you want to do your presentation and then
Yeah.
we can have more questions and go
Absolutely.
either to Amanda? Okay,
yeah,
great. Go
absolutely.
ahead,
I don't
Julie.
have slides prepared, so I was just going to kind of talk verbally, and I'll probably hit on some of those questions. So come back to me if I don't. But just to kind of introduce myself, my name's Julie, obviously, and I work for Petersburg Medical Center. We're located in Petersburg, Alaska. We're a small island community with about 3,000 people on the island. We're the only healthcare provider here. Petersburg Medical Center includes a primary care clinic, a long-term care, a hospital and ER. We have rehab therapy, physical therapists, occupational and speech therapy, and a home health agency. So we're all under the umbrella of Petersburg Medical Center. My job here is the community wellness manager. And so we've recently started looking at more prevention, health promotion and prevention. And so I do a lot of programs such as diabetes prevention, a lot of one-time events such as health fairs and walks and runs. But also this capable program, I serve as kind of the administrator of the program. So I myself am not an OT or an RN. My background is in public health and chronic disease prevention. So that's why I kind of landed in the community health, community wellness realm. And PMC has just started, Petersburg Medical Center just started the community wellness kind of department within the last 2 years since I came on board. So capable, one of the things that we were doing prior to COVID at Petersburg Medical Center was we were having a series of community cafes on different topics. One of those big topics in our community is a new hospital. So we'd had several opportunities for input from the community in these cafe models where we talk about what we need for a new hospital. Another community cafe we had was specifically on aging, because we have an aging community. We actually have a fairly older community. We have a lot of seniors here. A lot of people retire here in Petersburg. A lot of people that live their entire lives here. We do have an assisted living facility as well as our long-term care, but spaces are limited. And so one of the things that came out of that community cafe on aging was the need for aging in place resources for our community. We had somebody from AARP come and speak, and he handed out some great resources on aging in place. And people were just like, I want this. Can we have somebody come to our home and do this for us and go through it with us? And so it was well received, the idea of aging in place. So the hospital started kind of brainstorming, how can we support aging in place? At that time, I was not working at the hospital yet. Or I think I had just started, but in a different role. And they went ahead and received a grant. They saw this capable program in a rural health newsletter, and they were like, oh, this sounds great. We should do that. And so they applied. Our grant writer went ahead with the CEO and just like wrote this grant for capable. And like I said, the grant was this community initiative matching grant. So it was for starting new initiatives to fall under the category of health and social services for most vulnerable populations. And it's supposed to serve preventing mental and physical hardship and death. And so it does fit, but it also required a match. And so that's been a challenge. And they really didn't like the idea of the home modification. So we really had to push on that of why, they said, well, there are other grants out there for home modifications. There are other grants out there for that. And so this one really doesn't fit, but we were able to kind of get a small amount of money for the home modifications piece of the program. Again, I wasn't part of this discussion yet. So they received the grant in 2020 to implement the program. And then what happened in 2020? COVID hit and everybody had to go work from home. And certainly no seniors wanted people coming into their homes. And so I was working from home, and I kind of just took on this piece of, okay, we have this grant. How do we implement this program? Kind of those logistical pieces that Amanda was talking about. So I started talking to Johns Hopkins University, started that licensing process, realized all the things that are really entailed, because our grant writer really didn't know what the program entailed. And so found that like the things that were written in the grant really didn't match what we needed, like the licensing fees, for example, were not written in. The training for the OT and the RN were not written in, like training time for those people could not be charged to this grant because it wasn't researched prior to applying for the grant. So we did receive really good support from Johns Hopkins. That's one of the things I will say is Johns Hopkins University has been excellent support system for us in starting up a new program. So I would just, encourage, even if you're still just in the brainstorming phase, to continue your conversations with them. They've been very, very helpful, even before you become a licensed site. So to answer your question about staffing, so like I said, community of 3,000 people. We started in the middle of COVID, which was very challenging. We actually were able to serve 4 people in our first year. And that was not until the very end of that first year, we got 4 people on board. And let's see, so we served 4 in the first year, 3 in the second year, and we have 3 more starting right about now. So we've kind of started in a cohort model. They all kind of start about the same time. And our grant would have allowed us to serve more. We weren't able to get as many people as we thought we could, because we heard that there was this community need and everyone thinks it's a great program when you talk to them about it. But yet when you're actually trying to find people, it's actually been challenging to get people that are good fits for the program. And that meet our eligibility criteria, which somebody asked that in the chat. Our eligibility criteria, we serve seniors over 60. Some sites do 65. We started at 65. We started with 65 and low income and having difficulty with at least one activity of daily living. So they had to self-identify that they're having difficulties with at least one activity of daily living. This is something that your site can kind of determine. It's flexible. There are recommendations from Johns Hopkins, but it is somewhat flexible. So we lowered, after not getting very many people, we took out that low income part. We said, we don't need to just do low income. If there are other seniors that could use this service, let's serve them too. Then we lowered it to 60. And that has helped us get some more people where we're not asking about, do they fit into this income bracket? We have one admin person, which is me. I spend, I don't even know, an hour a week on Capable. It's very limited. And we have one OT who is very part-time. She works primarily seeing home health patients, but she does the Capable program as, it kind of ebbs and flows, but she's very part-time. And one nurse who is also in our home health agency, and she is very part-time for Capable. So she's, 90% home health nurse, and then she puts on her Capable hat and visits folks as a Capable nurse. And then as far as the handy worker, we actually did not hire anyone for, we didn't hire a handy worker specifically for Capable. What we have done is, because we don't have a lot of people, we wouldn't have hours for them all the time. We wouldn't have projects for them all the time. What we've done is, as we see someone and we get to that work order part and we know, okay, this person needs handrails installed, or this person needs steps into their home that are safer, then we reach out to a contractor and get that going with that contractor. So they're contracted for a specific job. And we have a list of contractors we work with for the hospital already that are licensed and bonded and insured, and that are set up in our system to invoice and pay them. So we have been fortunate. We found one contractor that we really like that is very community minded, and he's very, he'll kind of sneak in our little Capable projects on his long list of things to do. He's like, oh, sure, I can get you next week. Whereas others, may take longer to get in. And so he's very good in that way. And also he's given us significant discounts on things. When we say we're grant funded and we only have, $4,000, and that's the maximum we can pay, he built a ramp for somebody for $10,000 and just wrote off the $6,000. It was amazing. So finding that would be a, recommendation is finding some that additional funding, like Amanda was talking about, for critical home infrastructures or fixes. When you find somebody that their ramp to get into their own home is so unsafe, that's like the biggest thing that needs to be handled is just that ramp. And the other things can be secondaries. Having that additional funding source has been really nice, or a contractor that's willing to donate for, in our case. So that's a little bit about our program. Some of our successes, like I said, very supportive. Johns Hopkins University has been very supportive in helping us get it going. I told you about how many people we've served. I think in some ways, when I look back at, we started in the middle of this pandemic, but in some ways it was actually very helpful to have so much time for me to sit and figure out what's our recruitment and referral process going to look like, who are our partners going to be, what materials do we need, and forms and consent forms and brochures and things, like getting all that kind of in line. Taking time to do that was really beneficial. So starting slow was a success for us. We've kind of continued slow, but I think starting slow was good in our case. Partnering with our home health agency has been very successful. Not only do they have the staff, they already have an OT, and actually she's the only OT on our island. So it was kind of like, well, it's you or nobody else. And she loves the program and she's great. So partnering with them has been very good in many ways, not only for staffing, because we couldn't really, it's not sustainable to hire somebody for the occasional 2 hours, having somebody that has a full-time job within the hospital setting, and then they clock in and clock out of this capable department or grant when they do capable. Seems to work really well for a small site. And also, because they have that connection, that direct connection with doctors, the doctors are referring patients to home health. Home health may say they're not appropriate for home health, but we have capable, or they have just been discharged from home health. They no longer qualify. They've met their goals for home health, but we could support them in this additional way after they're discharged from home health. So our rule is that they can't be in home health and capable at the same time. And that seems to work very well for us, because it's kind of that division of, okay, what am I in the home to do here today? I am a home health nurse and I'm working on these things. And then once they're discharged from home health, they can come in as a capable nurse, even though it's the same person, and they can kind of focus on things in a different way, more focused on the prevention and not dealing with the medical issue at hand. So that's been very, very successful in kind of that continuity of care for some seniors. Hiring contractors as needed has been really successful for us. And then we've found that as we've gotten started, we've had a couple of people that have completed the program that have really served as good advertisers for us. So that word of mouth has been really good in our small community. So I think that will continue and help us get more participants. I think 2 of our newest ones came directly from somebody last year saying how great it was. So on to some of our challenges or recommendations. One recommendation that I have is to think through the steps that Amanda showed you on the screen of how to set up your capable site. We're right on. We did not follow those steps. Like I said, we got a grant first that was written by somebody that does not know the program. And then I was stuck on that grant. And when I tried to get an adjustment or I forget the word it's called, but trying to move money around within your grant, they were hard set, no, this is what you are doing. And what was the challenge with that was that all of our time in the grant was for OT time and nurse time. There was no administrative time for me. There was no training time. There was no licensing fees. There was no nothing for advertising. None of that. It was only direct service. So it was only the time in the home with the OT and only the time with the RN. But to start up a program, there's a lot that goes into it before that point. And so we were underspending in that area because we weren't seeing people yet. But there was certainly a lot of other things that needed to be done and time that needed to be spent, but we couldn't bill it to this grant. So I would just really encourage that you've done your legwork first. You've talked to Johns Hopkins. Perhaps you've secured that license in advance so that you have all the materials, because once I got the materials from Johns Hopkins, it became so much more clear how to implement and the details that I needed to work on. And then identifying your champion. Like I said, I wasn't even in the position yet, but they had secured this grant. So then I just got handed this grant to manage, and I was like, this doesn't even fit. How do I do this? And so really finding who's going to kind of be your champion, your administrator, and who are your partners? How are you going to do this recruitment and identifying participants? Kind of think through those things before you go for a grant, because then you know exactly what to put in that grant. So that was one of our biggest challenges. Another challenge has been getting referrals and recruiting participants, partly due to COVID. I kind of blame it on that. But now as we're coming out of COVID, I still find it's a challenge. And I've been, we started with, because we work within the hospital setting, we were able to run a report of seniors that met the criteria. So we started with, again, low income. So we started with Medicaid patients that were in our hospital system records, and we narrowed it down to 65 and older, and those that had more than 3 hospital visits in the last year. So we didn't want your frequent flyers in the ER that are having falls all the time as our first kind of participants. We wanted people that were doing fairly well, and we want to keep them doing well rather than focusing on our highest risk people when we did our first kind of round of invitations. So we started with letters, and we said, your doctor has invited you to this great new program. It's completely free. We did this nice letter in the mail, and we got nobody. And that was really frustrating. And then, we did presentations to our doctors and our nurses that are, up on the floor, and they were discharging people after falls or, other things going on, trying to get them to refer. Still got nobody. I can't remember how we ended up getting the first 2. It was a couple, actually, the first 2. And anyways, it's been a challenge, and we've done some presentations to community partners. We've given brochures out to community partners. We've followed up on those letters. I did personal phone calls to all the people on those letters. I think I got 1 or 2 from that. That's the follow-up calls, the personal calls, and talking to somebody. But many times when I talk to people that have either been referred or I've been given their name by, somebody, and or they've reached out. When I talk to them, they often say they don't think they need it. They live with their daughter already, and she helps with everything. Or I'm really doing pretty well. That doesn't sound like me. I don't think I need that yet, but I'm really glad to know we have that program here. And maybe in the future, I might need it. I found that a lot. And I feel like it's sort of twofold reasonings. Like, one, I think there's a sense of pride in our community, and probably elsewhere too, of, I don't need that. I'm doing fine. Not wanting to reach out for help. And we try to reframe it as, well, that's great that you're doing fine. We want to keep you doing fine. We want to keep you in your own home and make sure that you're preparing for the aging process. And then also the living with family. It's like, well, yes, sure, your daughter lives with you, but she's doing a lot for you. Are there some of those things that maybe you want to be able to do yourself? And we can help with that. So anyways, it's a constant re-education, not only to people that may be interested, we're kind of educating them on this. It's a very different model. It's a prevention model, and it's an empowerment model. It's not we're going to come in and fix the problem that you have. We don't just get a prescription from a doctor that says this person needs a ramp. Here you go. Now call Capable. They're going to build you a ramp. We do find that often we'll get calls like, I heard that you built so-and-so ramp. Can you build me a ramp? I need that. That's been a challenge for us, because then when we explain the whole program, they're like, oh no, I just need a ramp. Like, I'm coming back from Seattle, I'm having cancer treatment, and I won't be able to get in and out of my home. And so said, you guys build ramps. So can you build me a ramp by this day? I'm like, no, that's not really how it works. So anyways, there's a lot of re-education with potential interested people, and also with our providers when they refer people to it. I think there's been some miseducation from our providers. So that's a constant work that we need to do is education on what this program is really about. Another challenge is the cost of materials has gone up, and also living in a small rural community, things are expensive. and also limited availability. We try to order things and they can't ship to us. So that's been hard, but we're working on that. Staffing obviously is a challenge. And I talked about the grant funding. And so that's something that I've talked to our grant funder about, looking for that next funding source and really finding something that's more flexible and finding something that really meets the goals of this program and increasing that home modification budget. I love the idea, Amanda, of having like a additional funding source for critical home infrastructure needs, like the ramp that we built for $10,000. You know, that was critical to that person. It was completely unsafe. We were like, we're not even walking up that ramp. And so having additional funding that's outside of just, you know, oh, everybody's going to get $1,000. It was our original grant, was everybody gets $1,000 for the home modifications. If we had an extra pot that anybody could use if they were needing additional things, that would be really beneficial. So that's in a nutshell, my lessons learned, our successes and challenges. I'm happy to take questions, or Amanda, if you wanted to tag on to any of the things I said.
No, I was just gonna touch on the requirements.
Oh,
that you
sure.
talked about. So we started at 65 and we lowered to 60 as well. There are some places that it's 50 or older. That the age kind of depends on the site situation, what the organization wants to set, or is it grant? So like with our area agency on aging grant, it has to be 60. So that, again, it just depends on the funder and your organization. And what Julie said about self-acknowledgement, it's huge. The client has to acknowledge that they have difficulties. And Julie, what you said is like spot on when you're calling people, oh, I'm doing great for my age. Well, what does that really mean? You know, I live with my daughter and she does all that for me. You're exactly right. Was that something you want to be able to do yourself? You know, asking those questions, but they have to acknowledge they're having difficulties. Otherwise, we can't problem solve. We can't brainstorm with people who don't think they are having difficulties.
Yeah.
So we recommend at least difficulty in one ADL, dressing, bathing, toileting, grooming, hygiene, those kinds of things, or 2 IADLs, cooking, cleaning, laundry, medication management, financial management, those types of things. So acknowledge 1 ADL or 2 IADLs, along with being cognitively intact. So we need people who are going to be able to problem solve and brainstorm through things.
Yes, thank you. I don't advertise that part, but when we kind of do that initial assessment with people, we do kind of
You're monitoring that.
screen for that. And
Exactly.
also I think we've kind of said like people that are, you know, terminally ill is
Right.
another thing that we kind of screen out, but I don't advertise that part. It's just kind of as we get to know them and ask questions in that initial.
Exactly. So
intake.
when we're in our, exactly, Julie. So we are doing our screening process. We're asking about, are you currently receiving any active cancer treatments, or are you under hospice care? Because if they're seeking active cancer treatments, the risk of hospitalization is high. Plus the focus needs to be on them and that cancer treatment. So if there is somebody that's in the active stages of that, then we say, you know what, capable might be a really good fit when you're done with that. So we always leave that as an option later. But cognitively intact, able to problem solve and brainstorm. And then also you want to possibly look at how long do they plan on staying at home? Do they plan on moving in the next 6 months to a year? Because if that's the case, is it worth the investment? If they're planning on leaving their home. So
yeah, we built a ramp for somebody, a different ramp. We've actually built 2 ramps. Of the 7 people, we've had 2 ramps, and we built it. She was living with her son and son-in-law, and she needed a ramp into the house because she couldn't get into the house. We built a ramp, and then she moved. We were like, what? We just spent so much money. So
right. Yeah, and that's, you know, so that's challenging. And so asking those questions ahead of time is good. Again, so the criteria is mostly making sure they acknowledge deficits and that they're cognitively intact. Outside of that, the criteria is kind of organizationally set or funding set.
thanks, Amanda, for adding in. Does anybody have any questions? I don't know how long you guys have scheduled for this. Sorry, I'm
We
probably
had
going over time.
And unless people, we've got a few people dropping off, but any
Okay.
more questions that individuals have? Amy or Hunter? Heidi? Hmm? Okay.
I don't. I just came here to learn today. Learned a lot. Thank you.
Great.
I
Well,
actually have a question. I was just curious to know what a health passport is. That's a new term to me.
Oh, so it's a pamphlet that the Capable team put together as part of a strategy for the nurses. And it just talks about how to navigate like healthcare and things like that the nurse goes over. So it's very specific just to Capable that the team put together when they were putting the whole program together at the very beginning.
Thank you.
well, I've learned a lot, and I was sold on Capable 6 months ago, so I'm really sold now.
Great.
And we've seen similar outcomes that Amanda was talking about, the case studies, like they almost describe some of our people.
Yeah,
too. So
yeah,
we've had
yeah.
good outcomes with the few that we've seen all the way through. We've had a couple drop out, but basically those were due to health. One passed away, and one, was just declined health and needed
Mhm.
things.
And it's good because we're seeing the same health outcomes across the nation. So, I mean, Baltimore, Denver, Alaska, we're all three completely different areas, but yet similar outcomes, which shows the consistency of the program and fidelity of the program.
Right. Yeah, it's very significant. Well, I guess we will close, and I'm representing Meta at Home, and we're the ones that got you guys together. And so I'll have to go back to our board and Tracy and say, where do we go from here? And if anyone else wants to, Hunter or anyone else wants to reach out and say they'd like to partner, that would be awesome. Or have more discussions, I think maybe is the next step. So again, Amanda, thank you so very much. Really appreciate it. And Julie, so fun to see you from Alaska.
Thanks.